Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.
All right, welcome back to another episode of Pod Patrol with your host, Dr. Jeff Dikis. Today I'm joined by my friend, Travis Zimmerman, who is a medical device rep. Thanks for joining me, Travis.
It's awesome to be on. Thank you for having me.
Yeah, absolutely. So we were actually in the OR together earlier today. We were covering some cases, some fun, some not so fun. So take us back a little bit. I know that you played football in your earlier years. Talk about that a little bit.
Yeah, so I grew up playing sports. That's pretty much all we did growing up. So basketball was our main family sport, but then I kind of went the football route for college. I didn't want to have to pay for schooling, so that was kind of my way into schooling. My sister's was basketball. She ended up going to Iowa State, and then my journey was a little different because I wasn't getting recruited a ton out of high school, so I went to a powerhouse junior college right out of high school for a quick stint, and then I got quite a few offers after a year or two there. So I joined South Dakota State right after that, and then I finished my career up there 5.5 years later. So that was kind of my stint. But yeah, sports have been in our life our whole lives.
Yeah, college football, that's intense, and that's a big time program. They're always one of the top teams in their division, and so what was it like playing college football? Was it kind of grueling, exhausting, all the above?
My body feels it. I have 3 surgeries later. I've had 2 knee surgeries and a shoulder surgery. I played 2 years with a pretty banged up shoulder. And then finally after my career, I got my shoulder replaced, and that kind of got me interested in the medical field. And I was pretty close with my team docs, and I knew a couple team docs back here in central Iowa that kind of got me interested and thought I would be a good fit and personality wise for the OR and doctors. And that's kind of how that all but yeah, my body has felt it, but I would never changed it. The team camaraderie and the relationships I built, it's taken me probably to this job, and it's developed who I was as a person too.
Yeah, you and I are both big sports fans. I had to wear my Hawkeye gear. I know you're on the Iowa State side of things with your family and your sister playing basketball there, but it's football season now, so I got to rep my team and you can rep yours. So take us back to how it came to be that you got involved in medical device sales and being a rep for that. How did that kind of come to be?
So my senior year, right after season, I sat down with my team docs and we were planning out my shoulder surgery. I had pretty much got my whole shoulder redone, both sides of my labrum. Had a couple broken pieces of my humerus head that they had to take out and shave down, and a bunch of arthritis. So I'm sure I'll get a total shoulder down the road. But during all those meetings, they asked me what I was going to do after I was done. I really didn't know what I was going to do. I kind of wanted to do something in the business sales world because my mom owns a business, and I kind of just wanted to kind of do something that I had kind of some control over. They just said, hey, what do you think about the medical sales world? You're great with relationships. You're a very smart kid. You're very good with your time management. Would you be interested? So I was actually looking at Sioux Falls, South Dakota first. But this weird story was I had another option. I was going to go get my master's at Iowa State and then help the football team out because Coach Campbell recruited me and offered me when he was at Toledo. So I was just going to kind of help that out. And then when the striker thing came about, I didn't want to turn it down. I knew some of the guys and I knew some of the doctors, and they just said, hey, Travis, this is a life-changing career. It's a great career. You can make a great thing for your future and your family. And so that's kind of the route I took.
So you work for a company called Stryker. Is that a new company, or I haven't heard of that one before? Is that one of the new up and coming companies, or
No,
yes?
I don't think. Yeah, I don't think. I think it's. I think they've been around. I think we have like 22 divisions or something. Something crazy. Most hospitals, some of the hospitals, even in the central Iowa right now, are getting built by Stryker, just because we have so many divisions of everything from hospital furniture to booms, lights, cameras, monitors, all the way down to the hardware and biologics.
Yeah, they have a lot of stuff. So from my standpoint, you cover foot and ankle. That's how we cross paths. But you weren't always in foot and ankle. You used to do trauma. Tell us what covering trauma call and all that stuff was like.
Well, first of all, I started on the endo side. So I was with the endoscopy and sports med side when they were together. Got trained on sports med, and then I was helping cover all the endoscopy stuff. But and then I transferred over. They had an opening in the foot and ankle space. That was kind of the title, but there wasn't much foot and ankle business going on in our division, so they made me kind of switch over to the trauma side because we didn't have much trauma anyway. So I had to go to trauma training, and the trauma training is it's pretty grueling. It's similar to foot and ankle, but it's more with the orthopedic docs, and it's all the trauma cases that come into the hospitals. And there is some electives with the hand surgeons and clavicles and ankles that are elective. But in the foot and ankle side is more the DPMs and foot and ankle MDs and some orthopods. But we do more of the foot and ankle elective cases. There is some groups that take foot and ankle call, so we still do the trauma side of things. So that I was used to that, but just a lot less.
So what was it like doing trauma? I mean, you're getting called in the middle of the night, telling, doctors are calling you saying, hey, I need this, this, and this. I mean, that lifestyle has got to be a lot different than foot and ankle. Although foot and ankle, there's trauma involved in that as well. But what prompted your change from trauma to focusing more on foot and ankle?
I thought they kind of went hand in hand. We use the same products. There's a huge crossover between trauma and foot and ankle. The biggest difference, I would say, is that more the nailing cases of like the femurs and tibias. But everything else, plating, all the screws and stuff, it's hand in hand the same. Trauma and I guys are really close and we use the same product. So it was an easy transition. And we bought out a big company called Wright Medical. So we kind of once the merger happened, we kind of had to choose between the trauma and the foot and ankle side, which one to go, because they wanted to specialize more just because it was a bigger company on that side. So we kind of had to pick and choose. But I still help the trauma guys out all the time, and they still help us out all the time too.
So talk me through the training process. We, on my side of it, physician-based, surgeon-based, spend a lot of time training. We go to school, we go to residency, and then we figure out stuff that we didn't know previously when we become an attending, and new products, new devices, new techniques. Everything is constantly changing. So from you, someone that may or may not have had, a little bit of medical background, depending on what classes you were taking in undergrad, but to go from that to understanding anatomy and understanding what a fifth metatarsal plate is, and screws in the navicular, and that's high level stuff that you don't just learn overnight. So walk us through how a rep becomes trained and understands not only the products that they're carrying, but also the anatomy and how they're applying that.
They take you through a grueling, it's usually a 101, 201, and 301 course. And then they teach you all the anatomy in 101 and stuff, all the procedures, kind of the lingo. And then you kind of get in the 201, you kind of get into more of the product side of things and where you would use certain products. And then lastly is 301 is where it gets really challenging. They'll bring up like x-rays and stuff. And then you kind of like say, hey, a doctor sends you this x-ray, or they tell you about this x-ray. What would you do here? And they just kind of test and quiz you. They'll bring consultants in and stuff, and they'll teach the whole classes. But a lot of it is on you to learn and go to courses and go to class, learn online and develop your own knowledge. But that first 6 months is really grueling, where they really push you. And that's why you kind of start as like an associate. So you're training under somebody and you're going to cases with somebody. And that's a big advantage. And then they have tests and quizzes to quiz you how you do throughout these courses. Like Trauma is very grueling. They push you really hard. You got to get like 85, 90% on tests and quizzes to even pass the test, or they don't even keep you employed.
So is most of that online, or are there in-person classes, or how does that work for the most part? Because that's a
So
long time, 6 months plus of training.
back before COVID, a lot of it was all in person, but so now they do like the pre-courses online, and you study kind of like an online course in college or high school, and then 201, I believe they send you now to a thing, and then 301 is like an advanced course where they'll bring consultants in and really teach you stuff about X-rays and where put this plate, what's your options, stuff like that.
And then how do you keep up to date on some of the newest stuff? Because as soon as you learn one set, they're going to get rid of that set. And we bought this company, and now we have this set, and now we have all these new products that are coming down the line. So how do they keep you guys trained and up to date on the newest products that are coming out?
So the biggest thing is like if we buy somebody out, like we just bought out Artelon out for an example, Stryker Medical did, and we're like already doing trainings on that. We've already had 2 or 3 trainings on that, and we've had people from Artelon come in and talk about the products, the kits, the different from like for an ATFL Brostrom, what would you use? What kit? Achilles, what kit would you use? So they're already trying to get ahead of the game before we can actually even give those to surgeons.
Sure. So take us behind the scenes. Let's say that I call you at some inopportune time. You know, I've talked on the air before how now my hospital is closed on nights and weekends, so I don't have to worry about this anymore. But let's go back to the olden days, and I call you at midnight and I say, hey, I have an open tibial fracture, open bimalleolar ankle fracture, open medially, and I need a set, and we got to go now. So take us behind the scenes of how that works.
So that's going back to my trauma days, which I love. But you have to know the surgeon, what his preference is, if he's going to be doing cases like that. And then you got to talk to the hospital and have trays ready at the hospital. We had trays on shelf, sterilized, ready to go. And if you called, they were ready to go. And then after the case, I would usually bring restocks, or that next morning we'd be restocking the tray so it's ready to go.
So tell us what that means. That means if I use, a couple of 14 screws and a 16 and a couple of 12s, that you've got those screws ready to refill that tray, and it's sterile processed and back onto the shelf ready to go for the next time, correct?
Yeah, so like say you used 8 locking screws or 8 screws, a plate, and a couple K wires or something. Most people, if you're a trauma surgeon, we would have those restocks ready to go, or that next day we'd be filling the tray ready, sterilizing it again in case another case came in.
So that can be rather stressful because, if everything goes according to plan, it's very simple. Okay, I've got one ankle fracture. There's one tray on the shelf. 1 equals 1. We're all set. But now I get another add-on ankle fracture, and there is no set there. Now what do we do?
That's where, like, if you're a busy surgeon, I usually have 2 or 3 options for every case. That's my protocol. Some people might not do that, but I usually have at least 2 or 3 different options, even for elective cases. If we know, like for instance, this morning I had 2 or 3 trays for each of your cases, and that's just a habit I got into from the trauma side, because sometimes you do get burned where, hey, you have a hole in the wrapper or the tray's not sterilized. What's your next option? So you have to have those options because the patient's on the table.
Yeah, absolutely. And that's very frustrating as a surgeon. If something isn't going according to plan, I have to worry enough about how I'm going to fix it and the technical details of the anatomic dissection and all the details of the actual surgery. The last thing I want to worry about is the tray clean? Is it ready to go? What's the backup plan? So having a good rep on your team on your side is really important, because they can handle all that stuff, letting the surgeon focus on the details of the actual surgery. So as you get into the OR, what are things that what makes a good rep? When you get into the OR, what do you think? And then I'll share my side of it too, but what do you think makes a good medical rep?
I think coming from the trauma side, that's where I really learned a lot and grew up really fast. And I think that's where coming from and seeing the best reps come from the trauma side. I believe having the backup trays, having extra things available in case you need to go to square one, to square two, to square three, to even square four. Having different options if you need to go to a lower screw size, if the bone's not, if it's too small and that screw size isn't going to work, do you have to go down a screw size or up a screw size? Having all the nail lengths on the trauma side. If, say, like a hip nail is usually a 10 or 11, if it's a younger patient, go down to a 9, or if it's a bigger patient, go up to a 14. Just having those different sizes and not being accustomed to the ideal same surgery every time, just making sure those are all good. And then being prepared, texting the doctor before and after, chatting about the x-rays. What's the plan? What's the backup plan? I would say talk to the hospital, making sure everything's ready beforehand, not going into last minute, making sure everything's shipped in, shipped out, ready to go. The big thing, another big thing is pricing, making sure all your stuff's okay at the hospital these days. But I would say more just taking a lot of stuff off the surgeon's plates so they don't have to worry about that, and then making sure they're comfortable with you in the OR and making sure that they know that you have everything and the backups ready.
Yeah, I think to summarize what you just said, I think most of what you just said could be summarized with communication, communicating with the doctor, communicating with the scrub tech, the hospital, the sterile processing unit team, whatever you want to call it, but making sure everyone's on the same page. I think that's crucial, not just in what we're talking about, pretty much in all of business and life. Communication is important. Yeah. So from a surgeon's standpoint, I think the most important, the thing that a good rep can provide is that I don't know you're there. I'm not talking socially, we can chat and whatever, but I'm talking about through the case. If I don't know that you're there, that means that the case is going smoothly and I'm focusing on the actual surgery. I'm not focusing on which drill it is, which driver it is, which screw, is it cannulated? Is this the right locking tower? Is it not? If I don't have to stop and think about all those things, that means the rep is doing a really good job working with the scrub tech, being proactive, telling them, hey, he's probably going to want this. Hey, have this ready. Hey, pull this out. Hey, see these 2 plates? Pull those out. Have those. He probably is going to choose one of those 2. Feeling comfortable with surgeon preferences is important. And that comes with time, but it also comes with experience and knowing, okay, well, most people choose one of these 3 plates. Maybe it's the first time you've ever worked with that surgeon, but I know chances are one of these 3 plates is going to be the option. If not, we have a whole lot of other ones, but those are 3 ready to go. So I find that if I can work through a case and never have to stop and try to micromanage the back table, then the rep is doing a good job and things are going smoothly. So communication, but also being a well-trained rep and understanding the flow of a case, I think is important, because the quality of the scrub tech varies a lot. You've got scrub techs who've been doing ortho for 25 years and could probably do the case better than half the doctors. And you have scrub techs who are new on the job and don't know what the heck is going on. They can't even pronounce arthrodesis, let alone figure out what the heck is going on. And that's not a knock on them. It's just the truth, right? They don't know what's going on. And so having the rep kind of guide them through, I know that makes the surgeon's life so much easier and so much better.
And I agree with that too. And I think even some of the bigger cases that we get into, like with nailing, some framing stuff, some total ankles, we even do stuff with the scrub techs and nurses like a week or days beforehand. So they're prepared and they're familiar with the sets and the back table of how these jigs go on, how these frames go on, and they can play with it before going into the surgery, and that's the first time seeing it.
All right, so let's say you get to a case, and you've already said that you like to have backup plans, but I've certainly been in cases where the tray had a hole in it, or it wasn't ready, or there was a miscommunication. Although we talked about communication being important, sometimes things happen. Sometimes a lot of times that's on me. Just I'm in the middle of seeing 40 patients and I've got a patient that I'm scheduling, and then I text and I say, first J fusion. And then I move on with my day. And then I get to the day of and I'm like, hey, first J fusion hammer toe. And you're like, wait, what was that second part? The what? The hammer toe. You didn't mention that. Right? So let's just say that you get into a kind of a pickle. What happens when a tray isn't sterile or ready to go? What are the options?
That's where I think you need to be familiar with the surgeon, know what he likes, what he doesn't like, be
Or her.
familiar,
Or her.
her. Yeah, good point. And know the different options they like and then have those options prepared. But also, I've been down roads knowing what the hospital has on backup too. Like I've been in situations where I've had a hole in the tray and the surgeon wanted something different and then something else happened and I had to go to a different company that was on shelf just to get through the surgery. And that's becoming more familiar with the hospital, knowing the staff, what's there, what's not there. But of course, you want your second and third options. My car is full of stuff. Stryker's becoming more and more. They're sterilizing stuff in packets now, which is nice. So I carry it around a lot of stuff in my car just to have backups if something adds on, just like for instance for your case today with the hammer toe, we had stuff for backup. But knowing that, and that's a huge blessing on our part because it used to be these massive trays getting sent in and sent out and sterilized. So it's becoming a different world for sure.
Yeah, there's a lot of panic sometimes that comes with that. And so I've talked about it before. I've put a distal radius plate on a fibular fracture before. Sometimes you have to get a little bit creative and say, okay, what do we have? Let me see that. Let me flip it upside down. Okay, I could probably make that work. And so, if the patient's there, they're under anesthesia, things are expected to go one way and you got to be able to adjust on the fly. You do the best you can. So how long does it take typically to sterilize a tray that needs to be reprocessed? What do they tell you in terms of timing?
So each hospital is different with their credentialing and what they honor or not. But if it has implants in it, they you usually can't flash it. So flash means that you just put it through the sterilizer, steam, and then it comes out hot and you're ready. You can put it on there. But most of the time they make you wash it and then sterilize it if it has an implant that's going into the patient. So the wash usually takes between 30 and 40 minutes, and then sterilize usually takes about an hour, and then it's got to cool down a little bit. So yeah, you could be waiting for an hour or two if something happens, and that's why the backups are so crucial, having 2 or 3 options and then having some sterile options also.
There's also the benefit of opening those trays before the patient goes under anesthesia. You get the trays into the room, you get them ready, you get them opened, and if there's a problem, it's not too late. Patient's not under anesthesia. You say, whoop, hold on, let's wait, let's sterilize this, let's move you to the end of the day. I'll do my other cases, and then we'll have everything ready to go. So I think being there, being prompt, being early, having those trays open to find a problem sooner rather than later is helpful as well. So a lot of things
100%.
going on. It's easy to say, but especially when you're got multiple cases and you're flipping rooms and you're running multiple rooms, you're bouncing back and forth, you're going left, you're going right. There's a lot of things that fall through the cracks, but those are little things to think about, especially for younger surgeons listening. If you can open the trays ahead of time before the patient goes under anesthesia, if there is a problem, you're going to catch it and maybe be able to switch something up on the fly. What about
100%.
if there's only one thing in a tray and I drop it on the floor? Not me. I would never drop something on the floor. What if someone else drops something on the floor?
You about did today.
I did. I unscrewed a locking tower and it fell into my other hand that was resting underneath. It looked like a special magic trick, but it was just luck. But let's say there was only one of something in a tray and I drop it on the floor. What are the options? Does it depend on the hospital?
It depends on the hospital. That's where if it's an instrument, you can usually flash it since it's not an implant. So if it's very urgent, you can flash it. But that's where being a rep over time comes with very good knowledge and stuff too, because you can kind of make something else in the tray usually work. Say like a 2.7 drill guide drops on the floor or a 2.0 drill guide drops on the floor. You can upsize the drill guides to a 2.7 and still fit the drill through it. So it just comes with thinking on the fly and your knowledge of the trays and what the surgeon likes. And same thing goes with screws. If something happens with the screws, non-locking, you can't really do it, but you can always go down some with a locking screw just because they lock into the plate and you don't have to get bicortical.
Sure. So you don't have to deal with it with me, luckily for you. But how do you deal with slow surgeons? How do you deal with surgeons that are just so brutally slow? I mean, in my whole life, I don't think I've ever done a case longer than 3 hours. 3 hours is my tipping point. I don't care if it's the biggest Charco, Recon, Nail, Fusion, whatever. I don't think I've ever done a case longer than 3 hours. If I go over 3 hours, well, number one, I'm missing lunch, so I am not very happy. So
You were getting hangry today too.
I was, and it was only like 11:45. It's time to go. But how do you deal with slow surgeons? How do you deal with someone that's just like brutally slow? You just play on your phone and wait, or how do you deal with that?
No, well, hopefully no reps are playing on their phones, first off. But in our world, you can't really discriminate because you still need to get the business technically. So you gotta have some good, comfortable shoes, and that's why I got the Hoka's on. But you can't. You try to help them as much as possible, and that's where, if you've been in the game a while, you can really bring some value to the surgeons and say, hey, this is how a lot of these people do it. Would you be willing to try this? If they are, maybe speeds them up a little bit. But some people are just very nitpicky too with their dissection. It usually comes back to the dissection and closing part of that aspect of the surgery, of how they close and dissect down to bone. The hardware is usually pretty similar to compared to a lot of people, just because you're down and you have the site present. But yeah, it's a whole different game when you're used to. Some surgeons will do 8 to 10 cases in a surgery center. Other surgeons can only do 1 or 2 cases. It just totally depends on their preference and how fast they want to move.
Yeah, so how comfortable do you feel giving surgeons tips? You know, some are probably more receptive than others. Some have an ego. Some appreciate the tip. Some say, leave me alone, let me do my job. So how you just feel out the different surgeons that you work with and see who might be receptive to different tips, or how do you approach that?
100%. You got to feel out the surgeon, and you got to be around them for multiple, if not 10 or 20 cases, I think, before you really start speaking up in cases, or getting to know their demeanor or their attitude in cases. Even the nurses in the room, you got to just you got to know when a good time to chat up, and shut up is what I say. But yeah, younger surgeons usually love feedback because, like in our area, I think we have 60 to 70 surgeons we cover, or that are on our list to cover. Of course, we don't work with all those surgeons, but we see a lot of cases every week. And then a normal surgeon might only do 4 or 5 cases a week. So we're doing 8 to 10 cases a day usually between our team. So we see a lot of surgeons, and if the surgeon wants feedback, we'd love to give it. But we're not going to say, do it this way. We're just going to say, hey, we've seen it this way. You're more than willing to do it that way. This is how they do it. But some have an ego and they do it their own way, and you're not going to tell them otherwise.
Right. And again, you luckily don't have to deal with this with me, but how do you handle a bad surgeon? How do you handle a surgeon that, you know, puts a screw in and it just looks bad, or it's obviously not a good angle, or it's not a good bite, or it's missing, or how do you handle that? Because I've been around some surgeons who are absolutely fantastic, and I've been around some surgeons that they will not operate on me. Let's put it that way. So I've seen some things that are very questionable, and it's hard because maybe it is, maybe it isn't your place to say something. But how do you approach that? Because that's an awkward situation.
Yeah, it's a very awkward situation, but I think since I've been doing it for, I think, 6, 7 years now, the surgeons feel comfortable with me saying, hey, this doesn't look right. Or if I know a screw's not right, like I'll speak up and say, hey, let's try something different here. Especially the younger reps and colleagues, some of them don't like to speak up because they don't want the surgeon to think that they're telling them what to do. I say, like, in my opinion, I like to point it out at least. Then they don't think it's on me saying like, hey, why does it look this way? So I'll point it out of how I think it should look. And on my phone, I have even optics and everything and pictures of how stuff's supposed to look. So if something does happen, I'll pull a picture up and be like, hey, this is how it's supposed to look. It's your opinion from here on out, but I just want to point that out.
See how this looks? See how yours doesn't look like this one?
But
you should change yours to look like this.
But it's usually like our optics or something like that our company has published and tested, and that's where it gets on label, off label type stuff, and we don't need to go down that road. And that's where surgeons like seeing that sometimes.
Yeah, I think it's tough because it's in the best interest of the patient if someone speaks up and says, "Hey, this doesn't look right," or "Hey, it could be even more egregious. It could be even more egregious than that. But, you did something, you left something in, or something's not quite right. It's in the best interest of the patient for people to speak up and say, hey, this isn't right. You need to fix that. You need to change that. So it could be an uncomfortable situation, but I think it is, for any reps listening, I think it is. No, I know it is the right thing to speak up. Even if it makes an uncomfortable situation, it's in the best interest of the patient. That's why we're in the operating room. That's why we're doing what we're doing, is to try to help the patient, try to make them better, not to stroke the surgeon's ego, but to try to make the patient better. So any young reps listening, I think it is paramount that you speak up and say, hey, this isn't quite right. What about changing this? Or do you feel comfortable with that screw? It's a little long, or I think that screw, is that screw in the joint? Looks like it might be a little bit long there, just speaking
100%.
up and makes an awkward situation, but I think it's better in the long run. So,
and I think that's a good point where it comes back to, I've always been told by some traumatologists and orthopedic guys in this area that you're supposed to make your surgeon look good too. Even though like you're supposed to be ahead of the game, you're supposed to have the scrub techs ready and stuff. You're supposed to make the surgeon look good, but that's also about how the hardware looks, the final stuff. If there's a K-wire, say there's a K-wire up the nail or in the screw still, and you're about to forget to pull the K-wire out, it's like, hey surgeon, the K-wire's still in there, you need to pull that out.
Mm-hmm.
And stuff like that, just to make it more fluent and make your surgeon look good too.
Yeah, for sure. I need all the help I can get. So if you could just scrub in and just, change the angle of the wire every now and then, that would help me out. So as a rep, what are your goals? What are your goals as a rep? So it could be personal goals, and it can be benchmarks and sales goals and things like that. Because I think us as surgeons, we don't really understand that behind the scenes thing. So talk about both those personal goals, but also professional goals.
So I think every company's different in this aspect. In the sales world, there's always been this quota thing where a rep or a company's got to hit their quota or what they set out to get. Mm-hmm. And I think that can kind of go, some companies really strive for it, and some companies are like, hey, you're close, like you're in the ballpark, you're okay, and it's not like it's the end of the deal. But that would be the benchmark from the sales aspect. Some companies really want you to grow. Some companies want you to just have those relationships. But from a professional side, I would say learn as much as possible. I go to a lot of courses. I was just in Baltimore for a big frame limb deformity course, learning and doing some labs. But that would be the big thing, is just learning like crazy, going to a lot of courses, seminars, learning online, getting feedback from your surgeons. But the biggest thing for me is relationships. The sales world I don't like the sales word. I like the consultant word, but the consultant world wouldn't exist if you didn't have the relationship. So I think that's where the best reps are probably more the relationship builders, and knowing the surgeon, getting to know the surgeon, and then that surgeon can always help you professionally out too, because they can teach you so much.
Yeah, I think that's a good way to put it. So what do you think is the best way to train surgeons? New devices are obviously always coming down the line. Hey, we have this new MIS, this new whatever, and you want to get it in the hands of whoever. Let's say me. You want to train me on a new device. What's the best way for surgeons to train? And then I'll tell you what I think is the best way for me.
So first off, you got to get the interest of the surgeon. So that can be over a chat in the office, clinic, over dinner or lunch. You got to know what the surgeon wants to do, what they're comfortable with, and where they want to take their practice. That's the first off. Because you don't want to go into a surgeon that loves total ankles and talk about ankle fusions. It's just, yeah, they probably do both, but like, it's just, you got to know the surgeon preferences and their skill sets, to be honest.
Mm-hmm.
But the training wise, I would say getting in front of it, getting the sets into their hands first. And then I would say before surgery even, I would say practicing. If it's a simpler thing, I would say sawbones or even just showing them the set works. But If it's a more complex procedure, for sure doing a cadaver lab or taking them somewhere, doing a lab at their hospital and training even one or multiple times on that case before they go in and do it on a patient.
Yeah, I think that's good in the long run. I hate that stuff. I hate sawbones. I hate cadaver labs. I
I know
hate
you
all
do.
that stuff. I just do. It's close. It's close. It'd be like practice if you're in the NBA and you practice on your little Nerf hoop at home. Yeah, it's kind of like basketball, but it's not really the same thing. Just doesn't have the same feel. Understanding what you're doing and the stepwise approach, I think, is important. But I don't like sawbones or cadaver labs, so I'm one who will just take a look at it and then let's go for it. Let's use it. Let's put it to use. Let's put it to the test and see how it goes. And I think that ultimately works out. I feel pretty confident with that, and maybe some people don't, and that's okay. Sawbones are invented to get you some practice, and cadaver labs are pretty much as good as you can get without being in the actual OR on a real patient. So I think that stuff is very, very reasonable. So trying to get surgeons to try new products, do you struggle with that, or are surgeons pretty receptive to seeing new things or trying new things, or do they get stuck in their old ways? Hey, this is how I've always done it. It's how I'm going to always continue to do it.
I would say it's an area thing too. It's like some surgeons want to get on some of the new stuff because they want to get ahead of the ball game, maybe to promote their practices or something. Hey, like for MIS stuff, for instance, hey, I'm doing this. It might draw some patients or something. But other than that, I don't. Yeah, surgeons always like to look at it for sure, just to see if it'll help their practice. But I think they're always going to go back to their old ways. And then if something really comes out that they think can change, and I always say, does it speed people up? Is it better outcomes for people? Is it better for the hospital? Is it is there a pricing something or something along that lines?
Mm-hmm.
Otherwise, a surgeon's not going to go. He's not going to change his ways.
Right. Yeah. Some people are more stubborn than others too. So as we see changes in procedures and hardware, what do you think you've seen as the biggest change recently in terms of hardware? And, in my mind, I'm thinking MIS, obviously everything seems to be moving towards MIS. Is that kind of the biggest change that you've seen come along in your rather young career?
Yeah, I would say MIS for sure right now. And I wouldn't even say like a MIS procedure. Yeah, a lot of people are looking at the MIS distal osteotomies, the Lapidus, the MTP fusions. But I would say the biggest shift has been the MIS prepping, just doing way smaller incisions, getting a MIS burr in there and prepping the joints and then throwing percutaneous stuff. That'd be my biggest thing. And then, of course, you got from like the ankle fusion to the total ankle world. That's a big trend right now that wasn't around. It's been around, but I think it's growing like crazy. And then I would say some different things. Other things would be some advancement in some biologics and some and advancement in some plating.
Mm-hmm.
You're seeing this carbon fiber plating out there. You're seeing this biodegradable plates and screws. Like there's just a lot of stuff that could change, but like we just talked about, people are stuck in their ways too with the stainless steel and titanium too.
Yeah, for sure. All right, I think this has been a really good conversation to see kind of the behind the scenes aspect of what it's like being a rep and all the headaches probably that come along with being a rep. We on the surgeon side take for granted that the tray will be there ready to go. It'll be clean, it'll be sterile, it'll be fresh and fully stocked and all that stuff we take for granted. So I think this is helpful for people to see the other side of it behind the scenes and know kind of what goes into that from your point of view. So thanks for joining me tonight, Travis.
Yeah, thanks for having me on. Got to
All
see you
right.
twice in one day.
Oh, what a treat. What a treat. All right, buddy. Thanks for
All
joining
right.
me.
Thank you.
Thanks, everybody, for joining me on this episode of Paw Patrol with your host, Dr. Jeff Dikis. We'll see you guys next time.